Hi, everybody. This is Jane, and I am going to get us started out today. I would actually just like to first say thank you you're the group who got us started really diving into this topic. And I'm going to speak for both Betsy and I don't mean to put words in your mouth, Betsy, but it has really been fascinating to delve into some of the research, some of the framework, some of the thinking behind what do we really mean by resilience. And that's kind of what led us to coming back this title, in addition, just trying to find something that was a little bit fun, but kind of this concept of we need to be able to spring back if we are going to move forward. So let's start with just what are we doing with our objectives for today, what we hope to cover. We'd really like to just talk about what in the world do we mean about resilience, and especially how it applies to healthcare. Try to give you some examples just to ground the concept. Think about what are some of those things that support resilience within the organization. We'd like you to be able to walk away with a couple examples there, but also what are those things that we may be doing that are actually detracting from resilience? And then we want to tie it together with, so we all do a lot of work around quality and safety in healthcare. How is this both could be supporting, but are there other factors that may actually be deterring? In our work in quality and safety may be deterring our work in resilience. So hopefully all of you at the end will get a taste of each of these as we go through our talk. Please feel free to put questions into chat as we go. If there are clarifying questions, I'm just going to ask that the team stop and kind of pause us, because I don't want anyone to be confused as we're going along. But then at the end, we're hoping to have some time for discussion. So toss stuff in chat as we're going along and you're thinking about things, and it'll give us something to kind of chew on at the end. So, and the 2021 winner for term is resilience. I can't tell you how many different conferences or presentations that I've either participated in virtually, where resilience is on the menu. There's a lot of talks about resilience, and a lot of them kind of fold back onto, what do we do as personal resilience? And healthcare isn't the only industry that's really talking about this. It really is, as you look all across industries. And it didn't actually start with COVID, although I think COVID has driven a lot of this interest in resilience. It really started before then. And if we take a step back and think about that, it makes a lot of sense. We have so many things that are coming at us in healthcare or just in life in general. There's the issues around globalization, movement, the rapid movement of people and information in our world, things that we used to think we understood, like money, which used to be the dollars and quarters and things that are sitting in my wallet or in the bank. Now all of a sudden are Bitcoin and cryptocurrency. I don't even know what those are. We have threats to our climate. We have changes in our society. And all of those, I think, all of these factors are what's driving this interest in how do we make ourselves and our organizations more resilient to these changes. Today, we aren't going to try to solve all the world's problems. We are going to try to focus on healthcare and understand really what it means in our day-to-day lives as folks that are working in that industry. What are we referring to, and what do we really want resilience to do for us? So let's just start first with a definition of resilience. So if you just Google resilience, which I did to make this slide, you come up with the capacity to recover quickly from difficulties or toughness, or the ability of a substance or object to spring back into shape or elasticity. So these are two bowls, obviously. One, the little one on the left, is a red plastic bowl, and the other one, a crystal bowl. And I thought this really was a good way to think about these, because these bowls, in my mind, represent resilience and non-resilience. So the little plastic bowl is really designed to be used in situations where maybe one expects unpredictable things to happen. For example, you might give food to a small child sitting in a high chair in this bowl, knowing that it could get flung off onto the floor, but it's designed to bounce back to its original shape and be able to go back to functioning again for the next meal. The crystal bowl, on the other hand, has inherent properties that when something like that would happen, it will break and it won't go back into its normal shape and function. Both of them can function in the same way, but it's really the thing that makes the difference in the two is how they respond to when something unexpected happens. For example, hitting a hard surface. So while we call the red bowl resilient, we could call the crystal bowl what we often refer to as the opposite of resilience, or brittle. And we're going to refer to that as well as we talk about healthcare systems. So we want, in healthcare, you know, all of us know our days are fraught with things that we don't anticipate. As a geriatrician, I work in long-term care. I can anticipate that I've got X number of people that I'd like to visit with today, but my day rarely ever goes exactly as planned. I have to figure out how to be resilient through that. It's just the way of the way we have to deal with things. Unexpected physiology, unpredictable behaviors, or just things that we can't always predict. So we want to be more like that plastic bowl and being able to tolerate the unexpected. And that's what we want our systems to be. A brittle healthcare system is like the crystal bowl. It struggles to accommodate any kind of major or sometimes a combination of minor disruptions without ceasing to function or reducing level of services. I also want to touch on, before we move to the next slide, this differentiation between resilience and burnout. And if I had in my cupboard, if I had a burnt plastic bowl, I would have put it up here as well. Resilience is not the cure for burnout. And oftentimes there's a number of presentations I hear that they're like, well, we have a problem with burnout, so we need to help people be more resilient. But I'm hoping at the end of this presentation, you'll understand why I'm going to say, if you have burnout as your problem, you need to deal with that first, because burnout, you are not going to be able to be resilient if you are burnt out. So, for example, if we took this plastic bowl and melted it, we've now changed the inherent properties of that bowl. It's no longer resilient. We have to, and that's similar to our healthcare workforce. They don't have the same properties as inherent properties as a resilient workforce. We have to address the burnout, and then once you've addressed that, then you can move on to resilience. So it's kind of like, I like the analogy of trying to have a burned out workforce and asking them to be resilient is kind of like asking your car to accelerate when you have no gas. And we know that that can't be done. So the challenge, but we're probably not going to fix burnout in this discussion. We're going to talk about just this resilience and how do we make healthcare more like the plastic bowl and less like the glass one. So next slide. Oh, you're already on the next slide, sorry. So is yoga the answer? As I mentioned, a lot of the presentations that I hear on resilience seem to focus on what we as individuals can do to promote our personal resilience. And that's often through activities that increase health or wellness and things like that. And that's great because actually individual resilience is a big component of overall resilience in an organization. And if you have a healthy workforce can be more productive. And so doing things that help all of us in healthcare develop, maintain, promote our personal wellness and sense of well-being will help all of us be more resilient when we're in the organization. However, if we look to each of our workers and say, we want to, your personal resilience is how we're going to become more resilient as an organization, and we don't put focus on addressing organizational factors, what that really is saying to individual workers is that this term resilience, it's just a code for maximizing worker productivity. And it's a subtle, but I think really important concept that we can be more productive when we're feeling well, but that can't be our only approach to resilience. Otherwise, we're just saying, we want you to be like an athlete that is functioning at peak performance 100% of the time. And that's not possible. It's not possible for athletes. It's not possible for us as healthcare workers. So kind of again, thinking back to our plastic bowl, and if that plastic bowl represented healthcare, that plastic bowl has it's really a combination of all its components and all the factors that make it up and how they're bound together that make it resilient. And so that's really true for us in healthcare as well. It's all the factors together that need to be bound up and to make our organizations resilient. So what are some of those factors? This slide just lists the factors that we're going to discuss today. There is an additional factor, or there are additional factors, one of which I think is also a topic for a whole nother discussion, and that is resilience in our customers or our patients, and how do we also build resilience for them or support them to be resilient, because in many ways they're having more disruptions than we are. They're the ones that are coming into our systems with a change in health status, with fear, with worry, all of those things. So this isn't inclusive, but these are some of the four main ones if we can talk about today. So the first one that I'd like to touch on is this idea of individual factors. What are some of those individual factors in the workplace that help support resilience? One of them is people having a high team orientation, meaning that they really recognize and the team and appreciate and support cooperation and compatibility between them and their team members. The other is this value being placed on our combined knowledge, really understanding how it's all of our skills and abilities that need to come together to create and build that support for the next one we'll talk about, which is team resilience. And then confidence in being able to use our skills and knowledge. And that one is something that we don't often, I think, always talk about. We just assume that healthcare workers are confident in being able to use their skills and knowledge. But this is something we really need to make sure we are supporting, because we do need, and we'll talk about this in a couple of the later next things, but we need each individual to be confident and be able to speak up and be able to trust their skills and knowledge and bring that into the team. So then how does that factor into the team, kind of the next level up? Team factors that support resilience are quality of relationships. When you think about healthcare, really it's a very human-centered industry. We tend to, sometimes we get a little too focused on our processes. We'll talk about that in a minute too. But really it's a group of us that are individuals, people working together, and we really need those quality relationships are really key for building this team level resilience. And having a shared mental model of what are our priorities and what are we really trying to accomplish, what's our focus, making sure that we're all sort of on that same page. Adversity management skills and processes, a lot of jargon in that what I just said there, but really a way of what I mean by that is our effective team communication, coordination, and cooperation. So making sure we're good at really talking to each other, that we're using language each of us understand, that we cooperate and coordinate, and kind of that, you can kind of see how these start to tie together. And then the last one is that adaptability. Kind of again, going back to some of that confidence, everybody being confident enough in their own skills and ability that when needed, any person on the team can step in and into that leadership role if it's their skills or their expertise that's really needed in that leadership space. So really being able to kind of flex and be adaptable. So just kind of a quick example here. I think, kind of COVID probably gave us a good example to look at, especially for some of the smaller hospitals and rural settings. I know I work in an urban setting. My husband works in the intensive care unit. And I know there was a lot of times where smaller hospitals in Minnesota had people that were very, very sick, people that typically they would have transferred to a secondary or tertiary care centers, but weren't able to because there were simply no beds for them to be transferred to, which really then forced the team to adapt, to work together, to care for complex, acutely ill patients in maybe different ways that they weren't always set up for doing. I also think, rural probably is naturally good at this because I did in the past work in a rural hospital, and you never know what's going to walk through your door. And anything and everything can walk into your front door, and your team has to be ready for it and adapt to it. So that's some of the team pieces that I wanted to touch on. The next one that I want to talk about is the leadership factors. And so some of the leadership's role in supporting resilience is really, how do you design those operational supports to enable flexibility? So what I mean by this is that we don't want to be so rigid that everything that we fall in love so much with our policies, our protocols, our processes, that we have taken the ability to be flexible out of our workflow. And so this is one of these spaces, and Betsy will talk about this a little later, where QI and standardization, we may have there's a little bit of a headbutting here, because we do want some of our protocols and things are helpful to us, but if we really focus on them too heavily, we can't go and don't allow people to go outside of them. We don't give our teams or our individuals that flexibility that they need to use their skills and ability when something unexpected happens. In one of the papers that we read, they talked about this concept in when you're kind of in the moment in a disruption, this idea of the 10 for 10 timeout, taking a 10-second timeout to plan the next 10 minutes. And it's moving to that type of thinking as opposed to, well, what's our standard process? What's our standard protocol? The other thing that leadership really needs to do is focus on how do we create a culture that does encourage each member of the team to speak up, to say things that they're noticing when something unexpected may be occurring. How does it foster the team's appreciation of each of the different disciplines, expertise and skills, and how each of those can really be an asset when we're facing a disruption? And leaders themselves have to really do some self-reflection to say, I can't feel threatened. And if I put my physician hat on, I have to make sure I'm not going to feel threatened if there's a situation that comes up and somebody else on the team really is the better person to lead this. And I can't think, well, I'm supposed to be the physician. I'm supposed to be the leader. I need to be able to step back and let that person with the skills, experience, expertise lead, and not let my own feelings, or not let that disrupt my confidence in my skills, but instead be able to appreciate my team members' skills. And then leadership really needs to value staff with experience. We need to be able to say, who are those folks out there? Who are the people that have experience that's developed over time? How can they be the mentors? How can we really utilize that long-standing experience and expertise and use that to help then maybe continue to teach new staff, continue to teach other roles, no matter which discipline they come from. So it's really thinking about those leadership factors that really drive those things that are important for the team and individual resilience going forward. And then the last one I want to touch on is this role of resources. One of the things, and Betsy will talk a little bit more about this as well, but we've done a lot of work around trying to decrease waste in our systems and things like that. One of the things that is important if you're going to be resilient is to have availability of resources for these unexpected or emergent situations. That often means that we need to have a little bit of slush in the system. If we run ourselves so lean to reduce costs and be so inefficient, we may not have the resources to grab those extra things that we just don't need very often. We may not have them. We may have taken them out of our system, and now we're not able to be resilient because they're not there. So what it really challenges us is to say, not so much focus on that waste and slush, but to say, what are those things that could really be valuable in times of disruption? What brings value in our day-to-day work, but what are also those things that we may need to keep in the closet for times of disruption, and make sure we don't toss them out in our drive to be cost effective and efficient. One example I always think back on in my training was very, very early. Probably the earliest electronic health record I had experience with was back in training, and it was a great idea. They had these stations set up, and you had to either be a resident or staff in order to order things. But it took pressure off the administration staff, so they weren't always having to take verbal orders, weren't having to, put written orders into the system until a cardiac arrest occurred. Because a cardiac arrest occurs, and now the resident, who in a teaching hospital is the person who's running the code, but they're also the only one that can order out of the electronic health record. So the resident has to step away from the code, go to the electronic health record to order a chest x-ray, put in, is the person pregnant, is this, to get a chest x-ray stat. And so it's a great example of how very efficient, very cost effective, but when a disruption occurred, the resources were gone out of the system. I think the one we all can relate to with COVID is PPE. And, we have the PPE we typically need until a pandemic occurs. And then we have to figure out, okay, now how do we reuse this stuff? Where can we get more? How do we protect what we have? So a couple examples of just how important it is to make sure that we really think through not only resources we need for on a day-to-day basis, but things that we need when a disruption occurs. And then when and where does resilience actually happen? This was a framework, and it's from one of the resources that we have at the end, but this was from a fellow named Carl I don't know exact McCrae. I think I don't know exactly how he says his name. He's from the Center of Health Innovation and Leadership and Learning from the Nottingham University Business School. But it really resonated with me as I was looking at this concept of resilience, because we talk about, we can talk about the individual, team, all those factors, but so when and where does it really happen? And he divided it into 3 different kind of places. And so his first one is that situated resilience. And what he talks about there is this is that resilience that happens kind of at or close to the front line. So it's really, and he uses the term socio-technical resources, which is really just a fancy term in my mind for this interrelationship between, our technical tools, but also our human, our relationships with each other, and how we optimize both of the use of the technical tools and resources we have, but also how we optimize our social interactions and optimizing those jointly together to really get the best combination. So he talks about that, kind of right at the front line. So being able to, mobilize that. And he said, this is the kind of resilience that really has to happen really quickly. And it really ties a lot with some of those individual team skills. So this unfolds really over seconds or very short time frame. It's that first line of resilience when a disruption occurs. But then there's a structural resilience. And this is some of those factors I think we'll touch on in kind of the resources, the leadership, team building. What are those things that we're really doing within our organization to build the framework for resilience? What are those structures that we need to have in place? And that doesn't happen overnight. That happens as we learn and as we learn from disruptive events. This is something that we can build, and he says, over weeks to years. And then finally, there's the systemic resilience. And that's really kind of that overall kind of oversight of the system structure and all the different things that interact within our organization. And that really is how we really stand back and say, how do we really configure, reconfigure, reform, transform our teams, our technology, everything, and how it comes together so that we are really best positioned for disruptive events. And that's work that happens over months to decades. This is really, changing culture within the organization, teams, leadership. It's the big work. And this isn't something that happens overnight. This is something that takes time. And why I think this framework spoke to me as I was going through this is that it just pointed out this isn't, if we really want to start on this journey of becoming a resilient organization, it's not something that we can just kind of put a few things in place or talk about it as teams. It's something that we really commit to for the long haul. And it's all the way from our front line to how we design ourselves, how we function as leaders, all of those pieces. So it's really resilience is really a long-term commitment for an organization. Maybe the pandemic gave us a kick in the pants, but if we really say we want to go down this route, it's something we have to be willing to stick with. I am now going to turn it over to Betsy to talk a little bit more about some of the factors that are both supporting and hindering all this work that we're doing or looking to do in resilience.
All right, thank you, Jane. Good afternoon, everybody. This is Betsy. So as Jane mentioned, we've got elements in our work, in our day-to-day, and what we're trying to do around quality and safety that are both supportive to resilience, but we can also have some features that might be inadvertently hindering our efforts around resilience. And we just want to talk through a few of those examples with you. In our efforts around safety, we put a lot of focus on trying to reduce risk that might be associated with human error, or humanness, if you will. In quality, as Jane had mentioned earlier, we put a lot of emphasis on trying to develop and reinforce a standardized, reliable process. Other changes around us in our environment that also are features that could both support and hinder resilience can be things like, as we've switched to electronic health record, there's various payment mechanisms and other things that have been developed to try to curb the cost of care. And unfortunately, as Jane mentioned, also we've seen a rapid increase in burnout across our team members and settings. So if we look across these things, what are some of the features that support us and might hinder it? And I'm just going to go through these boxes briefly and give some examples for you to consider. If we take the idea of auditing and training, that we can use features of this or aspects of this to support our quality and safety, for example. Auditing can be a good way for us to see variation in practice and to support learning. But it can also create some perception of being watched, which can hinder our resilience, and that it might inhibit our ability to just improvise in the moment when the situation may call for it. Auditing can, as particularly chart review, for example, is a retrospective process, and it can help us see variation, but it has a limitation in that we can't know if that variation was related to drift in practice, or if it might have been related to the need to improvise in a situation. Sometimes that information is available to us, but it may not be inherent. So it can both help us from a learning perspective, but it has some limitations that may not help us from a resilience standpoint. With quality improvement, we use Plan, Do, Study, Act, PDSA, use root cause analysis, and these are good learning tools and mechanisms to support understanding processes, knowing where those systems or processes might be weak, where are their strengths, and we can come to rely on those to support us so that we can focus on critical thinking. We want those processes to be reliable and standard so we can put our time and attention where we might need that expertise. But it can also help or lead to or contribute to us developing a sort of implicit or explicit bias that people are a weak link. We develop those systems because we have some human potential for error. But where resilience is concerned, we value that human experience, and therefore the views of people, we think about people as the strong link from a resilience standpoint, as opposed to where there can be risk for error from a quality improvement standpoint. With lean, Jane made reference to this earlier, we're focusing on trying to reduce that waste, trying to decrease cost and the extra steps that are not adding value. But when disruption occurs, those additional or spare or infrequently used resources may really be critical and needed. So lean can have an inadvertent resilience deterrent by making the system more brittle rather than resilient, as we're referring to, as Jane mentioned with the bowl example. Adverse health event reporting, again, an important learning tool to look across events and understand those potential disruptions that can happen and try to build systems and processes to prevent them in the future. The challenge with adverse event analysis is that they are rare events, not unlike these significant disruptions that we're talking about, that can lead us to build in systems or structures or workflows that add steps that are only needed infrequently or may not have application across team, the usual workflow or culture for the local environment. So there's some benefits and potentially some challenges that we just need to be mindful of. Implementation science, a method that uses evidence, putting it into practice, considering variation and complexity of healthcare, and that it applies social networking and utilizing strategies around behavioral economics. Implementation science can be a way to put safety practices into place and allow some flexibility of the team to innovate and adapt in times of disruption. And it feels like implementation science, it has some application or ability to support resilience. Now, it's been used more commonly in research, but we believe that there's some elements of implementation science that could be delved into further to help support resilience in the organization. And then the last one I want to just touch on briefly is high reliability and high reliability principles. I'm going to just go through these kind of briefly, and you may be familiar with these and use these regularly in your practice in your organization. So first principle, preoccupation with failure, the ability to learn from failures and adjust as a result and plan for the unexpected. That feels applicable and feels familiar with some of the aspects that Jane covered before, that idea of learning from past mistakes. Reluctance to simplify. Sometimes in quality improvement, it can be easy to look for the simple explanation of why things went differently than we expected, or to look to what's most convenient from a standpoint of an action plan to address that. Not because people don't have good intentions, but because the challenges of the day-to-day can make that an easy option to go to, rather than investing the time in the more understanding those deeper features that might be at play. Sensitivity to operations is another principle of high reliability. That idea of decision-making being decentralized, giving confidence and putting confidence in teams that they have the ability to make choices and decisions when situations arise that call for adaptation or improvising. Commitment to resilience is another principle. That one kind of speaks for itself as to the tie to resilience. And then the last one is deference to expertise. And again, this is a feature that Jane talked about in terms of leaders recognizing that there are times when we need to turn over the role of lead to those that might have the best experience, expertise, and background to be able to respond to whatever the situation is at the time that might call for a different leadership skill and capability. So these are some of those aspects. They all have benefit to our our efforts in terms of quality improvement and safety, and they can also have some benefits to resilience. But we just need to recognize there may be some aspects of them that can actually hinder inadvertently our efforts to be a resilient organization. If we focus all of our efforts on controlling conditions, if you will, or trying to be as reliable as possible, we could potentially sacrifice our ability to be able to adapt when the picture is far more complex and uncertain. We could really get focused on trying to control the process and prevent adverse situations where we can. But in those complex adaptive systems, we need that ability to improvise and respond. And that can feel pretty disruptive, even more so when we're used to wanting to control the situations more effectively. If we can't adapt, then it would be really difficult for us to hope that we could then anticipate those disruptions, cope with them, and recover from those unexpected situations. I want to talk a bit about resilience and trade-offs. So Jane gave us that context of those factors that are important for resilience from the individual and the team, the leader, and resource perspectives. So let's just say we have all those individuals in place that have strong team orientation. They have deep knowledge and expertise. They're confident in their own skills. We have teams that understand and appreciate the members of the team, and they rely on them and feel confident in that their team members will bring those expertise when the time calls for it. We have leaders that model that for the team and individuals, that culture of speaking up and are comfortable with turning over the lead to others when the circumstance calls for it. And you've considered those resources that are needed when the next disruption happens, not if it happens, but knowing that it will happen and have a plan for that. So what else should we anticipate in that regard? Well, just at a very basic level, those unexpected disruptions are going to require us to go outside what is the usual policy or protocol. Now, given the last year, that probably feels like a very duh statement, not very insightful or earth-shattering, but we are used to in our day-to-day following a certain routine or process. But in the presence of those unexpected circumstances or disruptions, change in the process is going to be needed, and the usual process isn't going to cut it anymore. It may not even be an option for us to use or go to. If you think about the pre-COVID situation, connecting remotely at that time with the specialist may have meant that you were still bringing a patient into the clinic to make that remote connection to a remote specialist who was maybe in an urban area or some distance away. And then with COVID, everything was remote. You didn't even have the option of alternatives to that. Staff who would normally work in one area were redeployed to areas they had no familiarity with. And even for those who worked in those areas, the process of what their usual day-to-day was totally different. So you may feel like in your settings that you have a sense within your team that you do this all the time. This is kind of business as usual to be able to improvise like that. But are there any conflicting goals you've encountered or your team has encountered that made you unprepared to make the choices that might have been necessary or might have gotten in the way of your organization's ability to be resilient because of that conflict? By conflicting goals, what we mean by is that the situation calls for you to make a choice that would be counter to what is the usual practice, or would maybe actually go against what you would normally expect to happen in that situation. We call this out intentionally because expecting that there will be conflicting goals, those things that are counter to what you would normally expect or even what you would allow, might be needed. Those trade-offs to what you normally expect might be needed, and it's a feature of resilience that organizations need to consider in advance. And staff within the organizations need to know that leaders know those trade-offs might be needed in the face of those conflicting goals, and that they'll be supported when they need to make those choices. We say that because acknowledging that these conflicting goals are going to happen and trade-offs are necessary are a key feature of resilience in an organization. And it's not enough just to say that yeah, we know there's going to be conflicting goals and we might have to make trade-offs. You actually have to create the space for staff to practice and work through those in advance. So thinking through what are the problems that your organization might face in the context of the local team, the local environment, is really an important feature to help prepare staff when they might face those trade-offs, when those conflicting goals face them are the reality. If we say that no trade-offs can happen, then what we're really saying is resilience can't happen. And we need to understand that that is a need from a standpoint of a resilient organization. Let's think about also other things that support, when we've talked about leadership and culture and adaptability, and how those also are needed to support delivery of value-based care. In value-based care, some of the focus is on efficiency and lean operations or efficiency to try to reduce costs, for example, but they can be hindrances in times of disruption, as we've talked about. Value is not the same as lean unto itself. So you can have a very lean organization, a very lean process, and not deliver value. This is some of what we're grappling with today in healthcare, and we've learned that lean by itself does not result in valuable service. I want to talk just briefly, check my time here. Oh, very short on time. Okay, just very quickly. What Jane and I have found as we've dug into this information is we have limited capability to actually measure resilience in healthcare. And some of the tools that we've used and we talked about in terms of our quality and safety metrics probably don't help us know whether we have resilience in our system or whether we know how to quantify resilience in our team. And we'd be interested in what others think about that if you've ever tried to consider whether you have resilience in your organization or teams and how you might measure that. Okay, I realize we've got very little time for Q&A. And I don't know if anyone has added any questions into the chat, but we wanted to give you some food for thought in terms of quality improvement and safety and resilience. So in quality improvement, we put the focus on the process, but with resilience, it seems to require adaptation in real time. So our question is, when you're designing for resilience, does it cause us to rethink our approach to quality? I invite you to share any thoughts you might have via chat or to go ahead and take yourself off mute and share any comments you might have on that.
Betsy, I'm going to jump in. This is Rhonda.
Yes.
I think that even the presentation, you're shaking up the way we approach quality. So it's really, I mean, it absolutely is going to change everything and the way we think about it and require us all to do it very differently. So that's why I was so excited about this presentation today, because I knew that it was so different than probably what most of us think and live every day. So, and I guess as we're finishing up, I guess Betsy or Jane, any last words as far as advice?
I'm just hoping that we've left you with some things to think about, and maybe looking back, I would encourage people to look at some of the resources that we've included. There's a couple, most of them are pretty easy read. There is one book in there that has a couple really interesting chapters. But I personally, I think the thing that I found most interesting was that we just have to fight against this idea that we can solve the problem of burnout by being more resilient. And that's not really, we're not talking about that. And I also think that this is an area where rural could really lead the way, because you are already being in smaller organizations where people wear multiple hats, where you're used to working in consistent teams, where you have some social connection. As we were looking at those factors that create organizational resilience, I feel many of them are already in place in smaller rural organizations. so I guess I would challenge each of you to spend some time, struggle with this a little bit, but then think about how really, you know, you can come out and be the example for how do you teach healthcare to be more resilient, and what can we learn from your organizations.
Yeah, thank you, Jane and Betsy. This has been really thought-provoking, and I can just imagine so many people sitting out there going, what? We're going to do what? So I'm very excited. I think this would be a great topic for just a lot of discussion in a hospital with the leadership of, okay, what would we do with this? What would this look like? So anyway, thank you so much for really kind of pushing us to think differently. I do appreciate it. And I'm looking forward to having you both back in our next project year and do a second part to this, because it's a great discussion. So thank you. Betsy and Jane, thank you so much. It's been a pleasure working with you guys and listening. So we hope to work with you very soon again. Thank you.